So there are fewer than 600 UCNS certified headache specialists in the United States. And when you look at the geographic distribution of them, they tend to be concentrated in larger cities, mostly in the Northeast, with a smattering in the Midwest. We actually have quite a few in Texas, but Texas is a big state. There's still not enough of us. And then a handful out, on the West Coast. And there are actually states where there is no board-certified UCNS specialists in headache medicine. So given the magnitude of the number of people who have headache, and in many cases disabling headache, it becomes a real challenge for those people to find someone who's able to take care of them. Many people who live in rural areas, or for whatever reason they can't travel, they're kind of stuck with whatever they can get locally, and there may not be, even amongst general neurologists or their primary care physician, people who really have expertise and feel qualified and comfortable in taking care of them. I really wanted to do a study comparing care with telemedicine with in-office care, because there was really nothing in the medical literature to support the use of telemedicine and to really indicate that care by telemedicine was just as good as care in the office. So the way the study was designed was of 50 patients, consecutive patients that I saw in my office who had a diagnosis of migraine. And these tend to be relatively severely affected patients because I'm at a medical center and that's who I see. They were all offered the opportunity to get their follow-up care either by telemedicine or in the office, and this was randomized. So they had, again, flip of the coin, determined how you were going to get your care. And the visits were set up so that they were at the same interval regardless of what the patient was assigned to. So they came back for a visit between about 4 or 6 weeks, at 3 months, 6 months, 9 months, and 12 months. And the primary outcome was at 12 months. And we looked at various aspects of the whole process. So we looked at the number of completed visits. We looked at the duration of the visits. We asked people at baseline, like how far away they lived from the center, how long it took them to get to their office visit. We did measures of patient satisfaction, and we also did measures of migraine disability and number of migraine days. So we tried to look at the medical part of it as well as the whole patient experience part of it. What we found was that basically, as far as their medical care and their level of disability, that there was no difference. There was no statistically significant difference between the two groups. Patients who were randomized to get telemedicine were more likely to keep their appointments than those who were randomized to get in-office visits. The major difference that was statistically significant was the duration of the visit and the overall duration of time it took for the patient to fulfill that visit. So the average office visit was slightly shorter in patients who got their visits by telemedicine. I think it was about 20 to 25 minutes versus a little over half an hour for patients who came to the office. So there's the potential benefit for the provider to be more productive, right? And then there was a marked difference in the amount of total time that it took. So on average, the mean duration of what we would consider travel time, getting set up and getting ready, was about 35 minutes for the telemedicine group and slightly over 3 hours for the group that came to the office. So by and large, patients were satisfied. They were happy with telemedicine. They were able to get their office visits done wherever it was convenient for them, either in the privacy of their own home where they felt, many of them, more comfortable speaking with me, or some people did this at work. I had people who were doing their visits while they were traveling and on vacation. So it was extremely convenient for the patients. And there were pluses and minuses, I think, to both methods. There were people who felt like They would prefer to come to the office because they like the direct contact, they like the handshake and the touch, and just the feeling of being more engaged with their provider. Also, being in the office gives people the opportunity to get treatment. For example, if they were in the middle of having a bad headache, we could give them an injection of something for nausea and something for pain in the office. So there are pros and cons to it, but overall, the two groups were very, very similar in their medical outcomes. So I think this supports not only the use of telemedicine for follow-up care, but also the reimbursement of telemedicine in neurology and in headache medicine in particular.